Good morning. So I'm Dr. Halas, I'm the founder and author of Nitro Medicine. And today we're going to talk about pain and the mechanism of pain, and everything has to do with pain. So is anybody here managing pain? Pain management? Or have patients with pain? What is the percentage of success of your pain procedures? 60 to 70%. 60, 70, that's reasonable. And so, if you fail to manage the pain of the patient, then the patient will say, what to you? I feel the same before and after, so what we will do, right? The reality is that you do not fail. It is because that there is two kinds of pain that we need to understand. Pain generated from outside your central nervous system, we call peripheral pain generators, and pain generated inside the central nervous system, we call centralized pain. And we learn in our fellowships in pain management how to manage peripheral pain generators and neutralize it. So what do you do in your pain management? What procedures that you do? Injections, steroids, lidocaine, PRP, stem cells, all of this meant to neutralize the peripheral pain generators. But it's not meant to manage the central pain. So a lot of surgeons and pain management, when they do the procedure, let's say they're doing facet injection or SI injections, 70% would work and there's no pain. 30%, as you said, it doesn't work, and the patient will say, I don't feel any difference between before and after. And the doctor feels guilty because he feels, I failed it. There's something wrong there. Did I fail in putting the injections or the steroids or the PRP? What's going on here? The reality that you did successfully neutralize the peripheral pain generators. But what's missing is you did not manage the central pain. So what is the difference between central pain and how central pain is developed? We find out that any chronic pain from the peripheral pain generators, whether you have facet, SI joint, knee joint, hip joint pain, chronically, burn, fracture, chronic peripheral pain generators can lead to central pain generators, can change the brain plasticity and connection. They become sensitive. Not just that, but even after completely neutralizing the peripheral pain, after you manage it, there is really no signals, no pain signals coming from your joints or from your back or from the periphery. The patient still perceives the pain as it's coming from that lesion that you already neutralized by doing your injections, your PRP, your stem cells, your steroid and lidocaine. Why? Because the neuroplastic changes that happen in the brain can cause firing pain signals without any external stimulus or without any pain signals from the outside. So it's pain within, generated from your spinal cord and from your brain. And we call this central pain sensitization, central pain syndrome. And that's what we're going to talk about, understand it, explain it. So, not just that, but also central pain, chronic central pain can lead to peripheral pain. And peripheral pain, chronically, can lead to central pain. They feed back to each other. And so, central pain generator is a neuropathic pain that happens when the central nervous system does not process the pain signal properly. There is abnormal neuroplastic changes, connections, where they fire spontaneously pain signals without any external signal of pain. Peripheral pain generator is a nociceptive pain that is not part of the nervous system and caused by inflammation or injury such as osteoarthritis, rheumatoid arthritis, burn. So we are trained to manage peripheral pain, but we are not trained to manage central pain. So you did not really fail in those 30%. The problem is that you did not manage the central pain. A lot of patients, when they do knee placement or hip replacement, right? There's not really any pain signals because it's just metal there. But still the patient said, you know, doctor, I feel the same pain that's coming from my joint. And the doctor said, there's no really joint there, there's metal. So where that pain come from? It's from the brain, from your spinal cord, from the abnormal wiring of your brain neurons that fire spontaneously. It's like seizures, pain signals. And so the doctor will say, okay, I'll put you on narcotic, right? Is narcotic is good? Yeah, for short term is good. But for long term, it induces oxidative stress, which will aggravate your central pain sensitization. It makes it worse. So you need more narcotic, you end up with inductions, and the patient becomes like a zombie, right? And he doesn't see anything except that narcotic. So about 20% of patients with osteoarthritis who have their knee and hip replaced continue to have chronic pain. Sometimes we say, well, it's because neuroma developed in the joint, so they take radiofrequency ablation and stop burning it. Still, they still have pain. So the pain is not coming from the knee anymore, or from the head. It's coming from the spinal cord, and it's coming from the brain, which is called amygdala, and from the spinal cord, from the dorsal horn of the spinal cord. Today we're going to explain how this neuroplastic change happened. How the chronic pain, peripheral chronic pain generators, led to central pain sensitization. So, the pain has likely to become centralized. It's no longer caused by inflammation or injury. Now the pain is driven by dysfunction in the central nervous system, neuroplastic change, abnormal connections, seizures, firing spontaneously, pain from the brain. And how are we going to manage that? So up to now, I don't see much of doctors are managing central pain. They give them narcotics, they get addicted, and in fact, they make the central pain worse, and they end up with all the problems that we know about drug addiction, suicide, and all the complications. So let's start understanding pain today by tracking the pain signal, all the pathways, where does pain signals go, right? And understanding neuroanatomy, neurophysiology. I'll try to make it as much simple as I can and break it down and entertain you guys without losing the evidence base or the science content of my presentation. I'm expecting you are medical doctors, so it's not good for the public presentation. It's not public, it's a more professional presentation. So when I put my hand on a fire or a candle, a flame of candle, what would happen? I trigger a pain signal that will go through your peripheral nociceptive neurons, right? And then it will sign up through the dorsal horn, the spinal cord, with the central nociceptive neuron, which is what the spinal dynamic neuron, right? It crosses to the opposite side. Remember that? It gets to your thalamus, and that's where the patient says, I feel pain. Okay? So what would be the next question that you are going to direct to the patient after they say, I feel pain? How severe is the pain? Right? From 1 to 10. So that happened, patient will respond. After that signal goes to amygdala. When it gets into amygdala, the patient will say, my pain is like 9/10. Right? So amygdala process the pain. See that amygdala here? And gives the patient the ability to sense the severity of the pain. Right? So feeling the pain, thalamus gives that. Severity of the pain is the job of amygdala. Process the pain. Right? Okay, and then what would happen to that signal? It goes to the hypothalamus, right? And then the hypothalamus will give you what? The fight-flight reaction. Sympathetic activity goes up. Patients will be having this pain behavior. So when we are examining those patients, first we ask them to do the vital signs. Why is the vital signs important in pain management? Huh? So patient on pain, their heart rate goes up, right? You don't see some patient on pain that their heart rate is normal, right? The sympathetic tone is high, so we expect the heart rate is high. So that helps you to differentiate between people who are faking the pain, trying to get attention, medical attention, whatever they want, right? But real pain. And then they'll have all the pain behavior. What is the pain behavior? Response. Huh? Irritability. What else? Holding their breath sometimes, twisting around, right? Their facial expression, you can see very clear. It's somebody's on pain, right? And plus the pulse is high too. So this is real patient. He's on pain. And the amygdala process that and send it into many parts of the brain to give you that response, including the hypothalamus. Okay. Then, what is the next question that we ask for the patient? So where's your pain? Right? Well, my pain is in my hand here. Right? So who's responsible to localize the pain? When the pain signals goes to the primary sensory cortex. That's where the patient is saying, oh, I feel the pain, it's in my hand. Right? Okay? Then what would be the next question for pain?
What is the nature?
What's the nature of the pain? Exactly. And the nature of pain, who's responsible for that? Somatic sensory association area. They will interpretate that pain and give you what? The quality of the pain. Burning pain, stabbing pain, sharp pain, right? And what would happen to all those pain signals? Along with all the events related to the pain, the visual, the auditory, they will be stored as a contents into your hippocampus. All this information, not just pain signal and the pain event and the experience, but all the things that surround that pain condition, around that pain, will be recorded into your hypothalamus. Right? Okay, so pain context, memorization, and then threat assessment. Now, if it's just a flame of fire and it's a first-degree burn, it's a little thing, it's not a big concern, right? So, for me, if I happen that happened, that I put my hand in the flame, my memories will say to me, well, this is first-degree burn, don't worry about it. You know, I have all experience of this pain before, and it's nothing. It will heal. Everything is good. Calm down, right? So what will happen is the signal will go to your prefrontal cortex, right? As you see it here, which is your conscious control, and your conscious control will send the inhibitory signal to the amygdala, shutting the amygdala down, say, hey, don't worry, it's just a little burn, and it will go away. There's not much pain there, so you don't need to be irritable and crying and screaming and things like that. It's just, and we have all the experience of that. Remember when you have this thing? This is how your brain is talking to each other. Your thoughts process. So your prefrontal cortex will go ahead and suppress the amygdala to suppress that the pain behavior response. The drama of pain, and inhibit that. So that if the pain signal or the pain is a trivial pain, this is what would happen, right? Well, what would happen if I accidentally put my hand on hot stove and I burn my hand and the burn was so severe, let's say it is 3rd to 4th degree. Well, that's painful, right? What would I have? What would I have? I would have a huge pain signaling that would go all the way through your peripheral nociceptive neurons and then send the signal to your central nociceptive neuron, the spinal thalamic neuron, right? Goes all the way. Makes me feel the pain, but in order for me to feel the severity of the pain signal has to go where? To the amygdala, right? And then amygdala will process the pain and send it to the hypothalamus and other parts of the brain. And then what would happen here? You would have the pain behavior response. So what would be the pain behavior response that with this kind of pain that I now experience, putting your hand in the stove with a 3rd, 4th degree of burn? Cry, scream, you know, what other thing? Holding my breath like this. And I'm trying to prevent that behavior response because I don't want to be embarrassed in front of you, right? So your conscience will say, yeah, just don't worry, it's just a burn, don't worry. But it will be hard to control it, right? So see what will happen here. First of all, we will localize the pain by sending signal to the somatic sensory, understanding the nature of the pain. It's a burning pain, right? And then all of this advance will be recorded in the hypothalamus, in the hippocampus, right? And then the hippocampus will send signals to the amygdala and also send signals to the prefrontal cortex, telling you this is huge pain, this is a problem, this is like 3rd, 4th degree of pain. We have this before. You will not sleep at night, you will be having chronic pain for months, and all those informations assessing the threat will be sent to your prefrontal cortex. Your conscious will say, hey, don't worry, it's okay, you know, we're gonna put some medication, everything will be okay, so you don't need to behave the erratic behavior response. So they will try their best to, I will try my best to control myself in front of you because I don't want to be embarrassed by the, acting that I have pain, screaming and crying in front of you. So the prefrontal cortex will be sending signals to the amygdala saying, hey, hold on. But the amygdala will send respond back to the prefrontal cortex, say, this is serious. I'm not going to stop crying or screaming. This is real pain. And so my conscious control, I will not be able to control my behavior response. So I'll be screaming and crying in front of you that yes, it is serious pain, right? And my conscious cannot control the subconscious threat of pain and behavior and response. Okay, so who's going to be responsible for the behavior response? Hypothalamus is part, but other brain parts will be doing that as well. So my sympathetic will go high, my heart rate will go high, right? My pulse will go high, I'll be breathing fast, I'll be holding my breath, I'll be screaming and moving around and doing Valsalva maneuver, trying to, increasing my parasympathetic tone, doing all these things may help to decrease the pain, possibly increasing the endorphins to control the pain, but it's so severe, right? The other thing is that when you are on pain, your body will try to respond by trying to reduce the pain signals that's coming up. That's a kind of defensive mechanism, right? So you do the Valsalva maneuver, you're trying to decrease the sympathetic tone, right? Also, you're trying to increase your analgesic activity, descending analgesic activities, right? that would help to shut the pain that goes up. So after having pain, your analgesic descending neurons will become active and will help to put the brake on the pain signals that goes up. Those are defensive mechanisms to decrease the pain. So you have inside your body an analgesic mechanism. In addition to seeking analgesic aspirin, you have inside your body, or narcotic, you have inside your body endorphins and serotonin and epinephrine, which will be released from the rostral ventral medulla and from the locus coeruleus. It will release serotonin and norepinephrine and activate the descending analgesic pathway, which will help to control the severity of the pain. So, in addition of seeking analgesic from outside, right, narcotic, aspirin, whatever, for pain, your body also can activate your analgesic neurons and help to put the brake on those pain signals as you see it here. Okay? So those are endorphin secreting and endorphin secreting neurons. They are GABA neurons, and they will secrete inhibitory signals to stop that pain signals that goes to the brain. Is that clear? Okay. Of course, this is a severe pain, second, third degree, fourth degree burn. So it will be chronic, and you will be constantly having this pain, so it will not be resolved. So what will happen here? You will have this pain signaling chronically, day and night, bothering you, not letting you to sleep, bombarding over your spinal cord, dorsal horn, sending pain signals, releasing massive amount of glutamate, neurotransmitters, and causing activation, massive activation of the central nociceptive neurons, right, as you see it here. And when you release this glutamate from the peripheral nociceptive neurons, they will open up the glutamate receptors, leading to calcium influx, right? Did you see that? And calcium influx will activate the NOx enzyme, generating free radicals. And those free radicals will stimulate functional and structural proteins of synapses, and causing outgrowth of dendrites, right? Connecting with your peripheral nociceptive neuron that's bringing the pain into your spinal cord. So what will happen here? I'm forming connections, new connections between your peripheral nociceptive neurons and the central nociceptive neurons. Neuroplasticity, wiring, new wiring. What will happen if you increase the number of the synapses between the peripheral nociceptive and the central nociceptive neurons? What will happen to the threshold of the pain? It drops, and you become very sensitive. And what we call this? Primary hyperalgesia, right? So when you touch the area of the pain, just touch or pressing it like this, you will feel a lot of pain. We call this what? Primary hyperalgesia. Okay? Did you see a normal connection there? Is it abnormal? For now it's not. Because if somebody has a fracture, you need that primary hyperalgesia, right? Why? So you stop moving your hands, so you allow the bone to heal. If we don't have this primary hyperalgesia, then you start moving your body parts, then you're not allowing the bone to heal. So it is now physiological, right? So primary hyperalgesia is physiological. What else? Your pain signals are bombarding your central nociceptive neurons, causing release of glutamate, opening up calcium channels, leading to activation of NOx enzyme, generating free radicals, and those free radicals will signal your neuron to generate more of dendrites and connections and changing in the neuroplasticity and connect with nociceptive neurons, the peripheral ones, that's not coming from the site of the injury, but it's coming from the surrounding area of the lesion itself. Right? So what would happen here? When I press not the site of the injury, not the site of the burn, but just site around it, right? I would have pain, tenderness, and this is called what? Secondary hyperalgesia. Okay? So this is the primary one. Right? See that? Okay? Here is the primary. Okay? See that? Alright, so that's the primary. And then the primary, of course, continuing, then you will end up developing another connection, see, with the here, with the nociceptive neuron that's coming from the area that surround the lesions. And give you what? Secondary hyperalgesia. See, I'm not pressing into the injury, outside of it. And this is secondary hyperalgesia, right? See that? Continuing sending these massive signals will lead to more of neuroplastic changes and wiring of the neurons, right? Leading to forming synapses with tactile neurons that's coming from your hand. Normally we don't have that, right? But it's part of the defensive mechanism that now, even by touching your hands, it causes pain. What we call that? Allodynia. So now, allodynia, hyperalgesia, primary and secondary, is it abnormal here? No, it's not. It's physiological, it is necessary, so I don't move my hands, so I allow the process of the healing to take place. Is that clear? So it's not abnormal. So when you see somebody who's fractured and they say, don't touch me because I feel a lot of pain, even touch, that's not abnormal. It's normal because it's a defensive mechanism that helps allow your body parts to heal. Okay. And that's what we call what? Allodynia. In addition to progressive neuroplastic change that took place in the nociceptive neurons, right? What will happen also is that those free radicals will irritate the neuroglia in the spinal cord, causing gliosis, inflammation. And that will aggravate the whole thing, right? By causing progressive neuroplastic changes in the nociceptive neurons, right? And it causes regressive neuroplastic changes in the descending analgesic pathways of neurons. So those free radicals will cause decrease in the connections of the descending analgesic pathway. It causes atrophy, right? So what will happen here to the number of synapses in the descending analgesic pathway? It decreases. What would happen if you decrease it? Decrease the signals of a break. You will increase the pain central sensitization, right? And the analgesia, the primary, hyperalgesia, the secondary, and allodynia, right? Is that clear? So this is neuroplastic change took place in that spinal cord. It's still normal as long as you still have the lesion. It's to the point that those free radicals can open up calcium channels in the nociceptive neurons, the central ones, and cause the neurons to fire spontaneously. So neuroinflammation and the free radicals can cause activation and firing of the central nociceptive neurons where they fire spontaneously without any external stimulus. And what we call that? Phantom pain? Yeah. Okay. Or central pain. Up to here, as long as you have the lesion, everything that happened here, it's normal. It's part of the defensive mechanism. But once the lesion is being resolved and healed, I don't have any burn anymore, all of this neuroplastic change needs to be reset back to normal, right? Some patient, which is the 30% of those patients, that did not respond to the pain, or the pain management, neutralizing the peripheral pain generators, they will continue having these abnormal connections and continue having spontaneously firing of neurons and neuroinflammation of the spinal cord. And that is the central pain sensitization. That is being overlooked by most of the medical community up to now. Okay? Is that clear? Do you understand how peripheral pain generators lead to central pain generators or sensitization? Okay. So what will happen here is that the spontaneous firing of the pain, which is the phantom pain, right, will lead to continuing sending signals to the brain, right, bombarding the amygdala and your brain, right? And as we know, the signals goes to the thalamus, right? See here. And then to the amygdala, right? And then to the hypothalamus, right? Remember that? To give you that behavior pain response. And then the hypothalamus gives you what? The fight-flight reaction, and gives you what? Sympathetic response, right? But that sympathetic response, when it becomes overactive, then what will happen? You will have a condition, it's called complex regional pain syndrome. So now it's not just phantom pain, it progresses into complex regional pain syndrome. Those sympathetic activities in the hand become so severe to the point that those norepinephrine has been released, it will activate the LOX enzyme there, increasing the free radicals, causing inflammation in your hands, right? And also the sympathetic causes also vasoconstriction and gives you what? Complex regional pain syndrome, vasodilation, vasoconstriction, inflammation. And that is peripheral pain generated now, right? So you see the central pain generator sensitization, now it becomes what? Peripheral pain. Complex regional pain syndrome. So from phantom pain, it progresses into complex regional pain syndrome. That's serious, right? And that's where it's hard to treat. And the failure rate of complex regional pain syndrome goes up to 50%. And patients, they may end up with amputation. So in complex regional pain syndrome, what will happen to them? It just touch like this, they will have pain, right? Have you seen patients with complex regional pain syndrome? Right? They'll say, doctor, don't touch me. Right? They have severe allodynia and phantom pain and central pain sensitization and peripheral pain sensitization, right? And if you start to if you have a feather in front of them, they say, please, put that away. Right? Don't touch me, please, doctor. I'm very sensitive. And don't touch them. You will make the pain worse. Even the idea that you're going to touch them makes them generate pain. Okay. Let's go back. So here, we are touching the patient with complex regional pain syndrome. What will happen to them? The pain signal will go up again to the thalamus, amygdala, hypothalamus, and then it goes to some center. It's called what? Habenula. What is Habenula center? It's a no center. It's the hate center. It's avoiding center, a response center. Right? Once it activates the Habenula, it gives your body the response to avoid the thing that stimulated in the beginning. So the feather, if you put feather or you're saying, patient, I'm going to examine you, what will happen? Please don't. Who's responsible for that response? Is the Habenula. No, the hate center. The no center. The avoidance center. habenula. Not just that, the habenula will also send signal to the ventral tegmental area, the VTA, which is the love center. When you activate the VTA, it makes your body to seek the thing that activated, the rewarding center. It inhibits it, so it decreases your dopamine. So touching this patient now causes what? Decrease in dopamine, causes the body to avoid anything that decreases the dopamine in your body, makes you to avoid it. Who's responsible for that? Habenula. Suppresses the love center, which is responsible to secrete the dopamine and suppress the dopamine, and makes you what? To avoid it. Right? All our decision that we make currently, and the reason you are staying here, listening to this hardcore science, is just because some of you are geek like me, who likes to hear hardcore science, because it makes the dopamine high. Right? But if you don't like it, and if it makes your dopamine low, you'll be leaving the room. So all of our decision, instant decision, it's all about what makes the dopamine high. So what controls you and control all your decision is the dopamine. If I put in front of you a chocolate or a salad, naturally you will be choosing the chocolate because chocolate knows the dopamine more higher than the salad, right? But some of people who have been trained, educated, cognitive therapy, they can control that and can, with cognitive therapy, they can cause the salad, dopamine goes up and make a choice of salad because they hear about chocolate is bad and all that stuff, so that lowers the dopamine. And that makes a choice to the salad because salad now is causing, but by natural, if you don't have the education that chocolate is bad and salad is good, then you would choose, naturally you choose the chocolate, right? So all of our instant choices, decision that we make is about dopamine. And what makes the dopamine high? Let's say if you have two choices, and both of them goes dopamine high, right? Staying here or leaving goes with dopamine high. But what is more higher is your decision. So because you're here, then staying here, decision, makes your dopamine higher than leaving the room. Did you understand what I'm trying to explain here? That dopamine is controlling your instant decision, everything. Okay. Not just that, the habenula, this evil center, the no-no center, the hate center, it actually inhibits the serotonin and the norepinephrine. Did you see that? Locus coeruleus, rostral ventral area. The locus secretes norepinephrine, rostral is the serotonin inhibit, and decrease the serotonin and norepinephrine, which is part of your descending analgesic pathway. So what would happen here? More pain, right? Because now you're inhibiting the brake, the descending analgesic pathway. So you would have more central pain sensitization. Is that clear? Okay. I still have time? 33 seconds? Oh, that's the problem I have with this. Okay. Anyway, whatever you tell me to stop, I'll stop. But I'm trying to do my best here to break it down, to make it easy. Okay? But that's going to happen. When I make it easy and break it down, then it will consume a lot of time. So we try to wrap it. Okay. So what will happen here? As we said, this back center will suppress the serotonin and norepinephrine and decrease the descending analgesic pathway, right? In addition to that, as we know, this is the pain signals goes up, and this memory of touching causing pain, right? Causing activation of habenula, causing the depression, and all the events will be recorded. Is that clear? Will be recorded by your hypothalamus. You see that pain signals goes all the way up, somatosensory, and recorded, and all of this will be recorded into your hypothalamus area, right? Okay. Okay, so what happened here? Because of continuing bombarding your amygdala, what would happen to the amygdala center? Hypertrophy, progressive neuroplastic changes, right? In the amygdala. Same thing that happened in your dorsal border. It happened to the amygdala. And what would happen? Neuroinflammation and spontaneously firing pain signals without any external stimulus. So what would happen here? See this one? Let me show it to you. See this one here? I'm going to show it to you. Not this one, but this one. Did you see that? That circle? Firing and recording the whole event and activating your memory of the whole events that caused the pain. What is that condition we call it? Post-traumatic stress syndrome. So who's responsible for post-traumatic stress syndrome? Is hyperactivity, hyperatrophy, progressive neoplastic changes of the amygdala, which causing firing pain signals that will activate your bad memories and all the memories related to the event, and you have this back flashes, right? And you experience that pain. What is that? That's the post-traumatic stress syndrome. Okay. So how we manage central pain sensitization? We give them opioid? Yeah? Okay, give them opioid. What opioid will do? Will numb the nerve, will cause hyperpolarization by opening the potassium channels. But the problem with opioid, it activates the NMDA receptor, open up calcium channels, which activate the NOx enzyme, generate free radicals, and those free radicals will cause what? The neuroplastic changes, the progressive neuroplastic changes, and aggravate the whole thing. It causes oxidative stress, right? So here, what would happen here? The patient will say, give me more narcotic, right? And they will end up with addiction. Not just that, the free radicals cause receptor desensitization, blocks the immunoreceptors, preventing it from responding. So you need more narcotic. And it aggravates the progressive neuroplastic changes and the neuroinflammation, right? And all this new synapses, and makes it even worse. So narcotic, for short term, it's good. It numbs the nerve. But long term, it aggravates the central pain sensitization, makes the patient seeks more of narcotics. So what would be the answer? Give them narcotic? I'll give them CBD. I think giving them CBD is better, right? Why? Because CBD does the same thing like narcotics. They numb the nerve, but without causing oxidative stress, without opening up calcium channels, without activating NOx enzymes, right? So the choice is giving CBD because it gives you the same function of opioid without aggravating the central pain sensitization. In fact, it will treat it because CBD helps to counteract the side effects of the opioids. Okay, it also helps to decrease the neurogliosis and the neuroinflammation. Okay, what about other drugs that we do? We can give them tricyclic antidepressant and serotonin reuptake inhibitors will increase the activity of the sending analgesic pathway. Is that what you do? Right? We can give them gabapentin, blocks the NMDA receptors, which will block the glutamate and the calcium influx. We can give them non-steroid anti-inflammatory drugs, decrease the neuroinflammation. We can give them steroid, but we know the steroids and the non-steroid and the anti-inflammatory drugs, the NSAID, it has side effects, so you cannot really give them for a long period of time. You can give them B12, which helps to block the glutamate receptor, the NMDA receptor. You give them curcumin, which helps to activate the antioxidants enzyme, right, and neutralize the free radicals. Also, curcumin helps to block the COX and NOx enzyme, decreasing the neuroinflammation. You can give them alpha-lipoic acid, which will help to neutralize the free radicals. And you can give them exosomes, because exosomes will help to express antioxidants and anti-inflammatory cytokines. Okay? I think the time is over.
You're over.
Okay.
Good job.
Any questions?